Okay, here we are. Well, thank you everyone and good evening. Welcome and for joining tonight's NBCA Pep Talk, Patients Educating Patients. Our talk this evening is on hospital-associated venous thromboembolism, or HAVTE for short. This is such a critically important topic for us to be addressing. So thank you for joining us. I want to thank my co-host tonight, seven-time blood clot survivor, Todd Robertson. Todd, thank you for joining again. My
Yep.
my PEP husband, the second or first Tuesday of every month. And I also want to thank our clinical guests for joining as well, Dr. Elliott Haut, who's actually a board member of the National Blood Clot Alliance. He is an expert in VTE. I am actually going to read his bio. I'm going to try to shorten it up because we only have an hour, and if I read the whole thing, we won't have any time left. So Elliott is Dr. Haut, I should say, but we're very informal here. So Elliott is an MD, PhD, and is Vice Chair of Quality, Safety, and Service in the Department of Surgery at the Johns Hopkins University School of Medicine and at the Johns Hopkins Hospital. He is a professor of surgery, anesthesiology, and critical care medicine, emergency medicine, and health policy and management at Johns Hopkins Medicine and the Johns Hopkins University Bloomberg School of Public Health. His research focus is on the diagnosis, prevention, and reporting of deep vein thrombosis and pulmonary embolism. He was funded by a 4-year K Award grant from the Agency for Healthcare Research and Quality titled "Does Screening Variability Make DVT an Unreliable Quality Measure of Trauma Care?" He has been the principal investigator of multiple large-scale VTE-focused projects, including individualized performance feedback on VTE prevention practice, which was also funded by an R01 grant from AHRQ. He has been continually funded for VTE prevention work by the Patient-Centered Outcomes Research Institute. I know you're going to speak to us a little bit about PCORI and some of the work there this evening, for a project including preventing venous thromboembolism, empowering patients, and enabling patient-centered care via health information technology, and implementing best practice patient-centered venous thromboembolism prevention in trauma centers. He was the co-PI, principal investigator, and conference co-chair of the Consensus Conference to implement optimal VTE prophylaxis in trauma, funded by the National Institute of Health, National Heart, Lung, and Blood Institute. I'm going to skip forward here a little bit, Elliott, if you don't mind. But you have played numerous leadership roles in trauma surgery. You were the past president of the Eastern Association for the Surgery of Trauma, called EAST, and chaired the EAST Guidelines Committee. You were past chair of Maryland TraumaNet, and you were the lead author of a paper commissioned by the National Academy of Medicine titled "Military Trauma Care's Learning Health System: The Importance of Data-Driven Decision-Making," which was used to support the Zero Preventable Death Report. Elliott is a member of the National Quality Forum Trauma Outcome Committee. You were on the board of directors of the Coalition for National Trauma Research, who we love partnering and working with. And you sit on the Maryland Statewide Emergency Medical Services Advisory Council. You were also the editor-in-chief of Trauma Surgery and Acute Care Open. You are a well-known global leader in the VTE space, and we are so happy to have you here, and also delighted to have you on our board of directors. So thank you for joining us tonight.
Absolutely excited to be here.
Thank you. And just want to remind everybody that we are not here to give individual medical advice. Tonight's event is for educational information only, and you should always speak directly with your doctor about your own medical situation, because all of us are unique and individual and require that individualization. Okay, so before we get started, we always have our poll questions. And Todd is going to start us off with poll questions and results. Todd?
I am. Happy Tuesday, everyone. And a lot of you know the drill. For those of you who don't, these are going to be easy to answer. Just look on your screen. Our first question, poll question: did you experience a hospital-associated blood clot? Yes or no? Number 2, were you told about the risk of blood clots prior to your surgery or hospital experience? Yes, no, not available. And our third question: did anyone in the hospital, whether it be a physician, nurse, physician's assistant, ask you if you had any blood clot risk factors such as smoking, family history, hormonal birth control, pregnancy, or something like being overweight? Single choice, yes or no? or not available. And then we're going to read the results real quick. Once those come through,
I love the poll questions.
we learn a lot from those, don't we?
Really do.
It's awesome to gather that data. Okay, so let me just scroll back up to the top. That first question, did you experience a hospital-associated blood clot? 21% said no, or excuse me, 21% said yes, and 79% said no. Number two, were you told about the risk of blood clots prior to your surgery or hospital experience? 22% said yes, 37% said no, 41% not applicable. Our third question, did anyone in the hospital, physician, nurse, physician's assistant, ask you if you had any blood clot risk factors, such as the ones we mentioned? And 25% said yes, but 41% said no, and 34% not applicable. So thanks for answering that, folks. Leslie?
Yeah, so that certainly indicates that we have a lot of educational work ahead of us, I think, with
Mm-hmm.
this kind of responses. So Elliott, we're going to get into the meat of the matter now. This is very exciting. So, our first question for you, it's kind of a question, but explain to us what HAVTE actually is, because it gets thrown around a lot. And I don't know if everybody actually understands completely, myself included, what it is and why it's so important for people who end up in the hospital or have surgery in the hospital or leave the hospital after surgery to know about this. The CDC claims that 50% of all blood clots actually occur in a hospital or post-hospital setting, and that 70% of that 50% can actually be prevented. So walk us through what this all means.
Sure. So I think, we've been looking at blood clots for a very long time, and HAVTE has had two different meanings over time, and that actually leads to some of the confusion. So years ago, we used to talk about hospital-acquired VTE. So these are patients in the hospital for some reason, whether they have surgery or a medical reason or oncology or whatever, and they get a blood clot while they're in the hospital. They get a deep vein thrombosis or they get a pulmonary embolism while still in the hospital. And that was called hospital acquired, right? You acquired it, you got it while you're in the hospital. And that's what we were working on and studying and trying to decrease and research and everything. Over the years, the terminology has changed. And now we talk about HA as hospital associated. And part of that is patients are in the hospital a shorter time than they were for the same conditions, years ago. Now things that are overnight surgery or same day surgery used to be in the hospital for days on end. Things you stay in the hospital for 2 days for now might have been a week stay before. So things have changed. And now we know that you can get a blood clot associated with your hospitalization even after you're discharged and you go home. So say you're in the hospital, your surgery, you get a knee replacement and you're in the hospital overnight for 1 or 2 nights, maybe really short stay. If you get a blood clot at home or in rehab, a week later, 2 weeks later, we still count that as hospital associated. So it's not hospital acquired anymore, but it's hospital associated because it's related to you having been in the hospital, having been sick, having had surgery, all these other risk factors that we'll end up talking about. And your point is right on track. About half of DVT and PE are hospital associated. So half are just happening in the patient population outside of the hospital. And I know, I've talked to Leslie, I've talked to you about your clot and everything. You weren't in the hospital, it wasn't hospital associated. That's about half the time. The other half are hospital associated. So patients have recently been in the hospital, it occurs in the hospital or after discharge. The other half is like that. And we know that we as a medical community have not done a great job at prophylaxis, at prevention for those hospitalized patients. And that's what we're here to talk about tonight.
And so for folks who are not familiar with the term prophylaxis, what do you mean by that?
Sure. So there's things that we can do as physicians, nurses, the rest of the healthcare team. There are things that we can do to lower your risk as a patient for getting a blood clot either in the hospital or hospital associated after discharge. There's medications that we can give, all different types of anticoagulants. People call them blood thinners. It's close enough. There's some mechanical things we can do. I explained to the average patient, it's the squeezy boots that squeeze your legs while you're in the hospital. So it's mechanical. And those two are the main things that we do to try to help prevent blood clots in the hospital. We're not 100%. We can't prevent every single one, but if we give the perfect prophylaxis, we can decrease that rate significantly.
Okay, super. Todd?
So let's nail this down. So who is at risk for hospital-associated VTE? Are there specific healthcare associated factors that increase the risk of developing a DVT going into a PE? I mean,
There are. And if
yeah,
you don't mind, I know we had talked about it before. I do have some slides, and sometimes I think it's useful for me to put up a few slides. I'm going to bounce around. I'm not going to
yeah,
go 1, 2, 3,
No,
4, 5,
that's
6,
great.
7.
I
If you
know
don't
people really
mind.
enjoy the slides, so feel free to share all
Okay.
of them.
you bet.
Here you go. Give me 1 second. Let's make sure this is up and running. Tell me when you can see it. You guys, you good?
Gotcha,
We're
gotcha.
good.
Yep.
Okay. So I'm going to jump right to the question Todd asked. So this is a list of risk factors for venous thromboembolism in hospitalized patients. Okay. And I give talks to lots of different groups. I'm a surgeon. I do surgery. I do trauma. So I focus a lot on trauma and surgery. But almost every patient in the hospital is going to be at elevated risk compared to when they were at home. And some of the specific risk factors, and Todd, this is kind of what you were asking about.
Hmm.
This is what the list looks like. This is not all inclusive, but it gives you a feel.
Sure.
So older patients are at higher risk than younger patients. Anybody with cancer, especially getting active treatment for active cancer, elevated risk. Chemotherapy falls into that. One of the highest risk factors for getting a DVT or PE while you're in the hospital is a previous DVT. Once you have one, and Todd, we heard your story, once you have one, you're at risk every time, either for getting one as an outpatient or every time you're in the hospital for something unrelated, you're at elevated risk for DVT.
Yeah. Yeah.
Trauma, we talk
So,
about this all the time in my trauma patient population. Trauma, surgery, hospitalization in general, lots of different things. And if you look at this list, it's very broad, right?
Hmm.
We've been talking about, elderly patients with cancer, et cetera, but women, pregnant women and the postpartum period, elevated risk for deep vein thrombosis, pulmonary embolism. All these things are going to raise an individual person's risk for deep vein thrombosis and pulmonary embolism while you're in the hospital, but also while you're outside the hospital for some of these as well.
so Elliot, there's some things on here that surprised me. First of all, you've got a lot of risk factors here, but not all risk factors are equal. Is that fair to say that there are
Correct.
some that are more
Correct.
important? Maybe you could highlight some of those for us. And also varicose veins, that's a new one, in terms of a risk factor.
And that one is a much weaker risk factor. These are not in order of quote unquote most important. And
Mhm.
varicose veins might increase your risk a little bit, whereas things like cancer, major surgery, trauma, those are the ones we think of that increase your risk. It might increase your risk twofold, fivefold, even tenfold if you have major surgery versus you don't. So we take care of a lot of younger patients on the trauma service who are very relatively unlikely to get a deep vein thrombosis as an outpatient. But then when they come in and they're injured in the intensive care unit getting surgery after trauma, their risk for DVT-PE is much higher.
Hmm.
And
Isn't infection kind of up there towards the top too? I mean, you're in a hospital setting, right? You've got all kinds
Exactly.
of things roaming around.
Right, exactly. So anybody in the hospital is at elevated risk and infection specifically, but also patients with cardiovascular disease, lots of
Hmm.
different things put patients at risk.
yeah.
Hmm.
And when you say hormone therapy, are we speaking about hormone therapy related to HRT? Are we speaking about birth control, both?
Fair question. So the one we hear a lot about is birth control related. There's a lot of young women on birth control, and their risk of DVT-PE is significantly elevated compared to peers who are not on it. And we hear stories all the time of young women who go to the emergency department with some complaints of something that eventually turns out to be identified as a DVT or PE. Oftentimes that gets missed because the patients are 22-year-old and otherwise totally healthy,
Yeah.
and that key risk factor isn't asked about and isn't considered And we hear stories, I would say, every year of someone who has a bad pulmonary embolism outcome or dies from that exact issue. And the only risk factor that was identified is that they were on hormonal birth control.
Mm. And how would you identify, or how would you explain major surgery to us?
You know, it's a great question. I think, you know, people say, well, any surgery I'm having is major, and that is true. And we're not talking about small, you know, cataract surgery, eye surgery, outpatient, you know, you go to the dermatologist who takes a little mole off your arm or things like that. You know, in the hospital, the major surgery we do is, you know, large abdominal surgery, big abdominal cancer surgery, cardiac, vascular, thoracic surgery, you know, joint replacement,
knee surgery, hip
knee
surgery.
surgery, absolutely true. So joint replacement surgery is
Hmm.
one of the highest risk factors. And the orthopedic surgeons have been working on this for 30 years since I was an intern about what's the best thing to do to prevent blood clots in patients after hip and knee replacement. The surgery itself is much, much better now,
Hmm.
but the risk of DVT-PE is still real.
Yeah.
It's really interesting. Okay. All right. Would you like to share other pages here or?
Sure, I'm gonna go back a minute. Let's see if this works. Let's see if I can get this to go. I just, you know, here's where we'll start. You know, we talked about what VTE is a little bit, you know, just so to get everyone on the same page. Venous thromboembolism, as we're talking about it, is comprised of deep vein thrombosis, a clot in the large veins in the pelvis or down into the legs usually, although they can be in the arms as well. And then the concept is those clots break off, travel through the veins to the lungs and become a pulmonary embolism. So
Mhm.
that's what we're talking about VTE when you're hearing those words. And you know, this is a report that came out from the Surgeon General. It's old now. This is 2008, and the data and the numbers are higher than they used to be. We think that this number is probably about 1 million Americans every year are affected by DVT-PE. About half of those events are hospital associated, just like we talked about before. And VTE is really deadly. It kills 100,000 patients every year in the United States. And I think the average person in the public doesn't really know that and doesn't appreciate that.
Right.
When you hear the numbers that it's more than breast cancer, motor vehicle collisions, and AIDS all combined, people are often really, really surprised. But then people also say, oh, I guess I shouldn't be surprised. My neighbor had a PE, my cousin, my friend, my whoever. They can always pretty quickly think of somebody that's like that.
Hmm.
So I think this is why it's such an important thing to think about. It really is a public health crisis, I would say.
Yeah.
And then I was just going to say, this is the Surgeon General who put that report out. And then this is the team, this is the Johns Hopkins team. I've got a pharmacist, a nurse, Mike Strife, who's a hematologist that we've been working on. And we hosted the Surgeon General right after that report came out, and really, really trying to help, you know, tell people all about it, raise awareness. There's a few other things I'll talk about. You know, we talked about these risk factors already. It's very expensive. You know, the total annual average cost that as it impacts the US economy is $10 billion per year. And yes, that is billion with a B. It's a huge amount, and that's data from the CDC. It's a huge, huge, huge amount that is the downstream impact of all these DVT and PE. And
Yeah,
then
and it's on the increase. I mean, according to the American Heart Association, it's actually going up. The incidence level is going up.
yeah, I mean, people think about, you know, cardiovascular disease, and people really think about, you know, heart attack, you know, MI, and stroke. Pulmonary embolism and DVT is the third leading cause of cardiovascular death in the United States. So it is a huge thing that people, I think, underappreciate. And I think that's one of the reasons that we're having this discussion here tonight. You know, as we focus on the inpatient or the hospital associated, much of this is very preventable, like Leslie already told us. Um, you know, we're not perfect. All the prophylaxis, those things we talked about are not perfect. They don't prevent every single event. It's not as though we give you this medicine and then all the DVT and PE goes away. but it reduces it dramatically. And then there's lots of evidence of what we should do. So these are guidelines. So these large national organizations put out guidelines that are aimed at clinicians like me as a physician, nurses, advanced practice nurse practitioners, PAs, etc., of what we should be doing for patients. There's really, really good evidence of what we should do for patients in the hospital to prevent these blood clots. Unfortunately, it doesn't happen all the time. This is an old paper, but the data rings true. In this group of patients, only 40% of patients had gotten what the guideline recommended. This is a big multinational study from literally all around the world, 32 countries. Look at the percentage of patients who are getting appropriate prophylaxis. It's embarrassingly low, right? 40% for medicine,
Yeah.
60% for
It
surgery.
is embarrassingly
It
low.
is. And this actually led to the American Public Health Association putting out this quote, which I really like. You know, the difference between evidence and execution as it relates to DVT is a public health crisis. And I'm not the only one who calls it a public health crisis. This is old. This is not new data. This isn't cutting edge. This is 20-year-old information. We're doing much better, but we're still not perfect.
Yeah,
I
I
thought
think
that was kind of what I wanted to kind of set the stage for. And then you and Todd, you know, ask me some questions and I'll pop around because I've got a bunch of different slides on a bunch of different things.
so. This is great. So, you know, you've shown us that there's a lot of risk factors out there that patients aren't getting a lot of the information that they need, or they're not being treated appropriately. So how do we stay safe? I feel like there's a massive burden being placed on the shoulders of the patients to make sure that they're being taken care of appropriately. You know, do you go in, do you say, hey, doc, I need a risk assessment? Is it making sure that you're getting the appropriate anticoagulation? Like, how do we protect ourselves from this?
It's a great question. I'm popping around the slides and I'm going to show you in 1 second. So I think part of that is we need a better system. And this is where, and I'm really, this is kind of a high level overview. A lot of the things I'm going to talk about, we've written tons of papers on. And when I say we, it's partly the group I work with at Johns Hopkins, but it's also tons of other researchers around the country. Systems are the way to improve care. So this, I think, will give you a feel of how do we prevent hospital-associated VTE. Okay, so it gives you a feel of what we should be doing. And I like this overview because it gives a little bit of everything of each step that's really important. And each step along the way is critically important. If you miss one step, you're going to have a lower efficacy of the interventions that we're trying to do. Okay, so what we really want is perfect care. We want to do all the steps exactly perfectly to have our best chance of preventing these blood clots. Okay, so a patient's admitted to the hospital. And the first thing we should do is we should do a risk assessment. So you might ask, well, what is that? There's lots of different ways to do that. There's not one standardized way. We have a way we do it at Hopkins. We've published on it. It's very effective. People might have heard of the Caprini model, which is another way that people do a risk assessment. And it comes up with these risk factors. And it might be a checkbox where you go on an iPad and check off yes, 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 or each thing has different points and you add up some points and figure out what risk an individual patient has for DVT. So step one is we should be doing that, whether it's a nurse, a physician, someone should be doing that to figure out, you know, Leslie gets admitted, what's Leslie's risk of getting a DVT PE while they're in the hospital? And then the question is, we're going to order some potentially medications or those mechanical devices based on the risk assessment. The highest risk factor patients might get both. Patients that are a little lower risk might get medications, and there might be patients that are at such low risk that they don't need anything. I think in surgery that those patients are few and far between, but there's likely some medical patients that fall in that category. So step one is we do the risk assessment. Then we should order whatever the right thing to do is. And then the key is the patients actually have to get that thing. So some of these medications are pills, some of them are shots. Some of them are given once a day, some are given 2 or 3 times a day. The key
And
is,
when you say these are all anticoagulants.
yes, these
Okay.
anticoagulants. And like I said, each different patient population has different data on what are the right medications. So if you have a joint replacement surgery, you might get one of, 8 different things. You might get some sort of injectable heparin. You might get direct oral anticoagulant or DOAC. You might get warfarin. You might get aspirin. So there's data for all of those different things in different patient populations. But they're recommended and it's like I said, it's once a day, twice a day, 3 times a day. But the patient has to actually get those medicines while they're in the hospital. And as patients miss doses, their risk of DVT and PE goes up. You miss 1 dose, your risk goes up a little. You miss 2 doses, it goes up a little more. The more doses you miss, the higher your risk of getting DVT, either in the hospital or after discharge. So now we're doing all these best things for the patients. Some patients might have an event while they're in the hospital, but most won't. They'll go home, they'll get discharged to home or to rehab or wherever. And some patients will have these post-discharge events. They might come, and this is a Johns Hopkins algorithm specifically. That's why it says Johns Hopkins Medicine. They might go to a different hospital. We have other hospitals in Baltimore. They might go somewhere else and we don't even know about them because they don't come back to us. Or they might come back to us in our clinic, in our outpatient, in our emergency department, or admitted. They might have events that way. First of all, the whole thing starts all over, but then we know we can follow and track patients. They had an event, it was hospital associated, and then we track and find out, what did we do wrong? Did we miss an opportunity to do a risk assessment? Did we miss an opportunity to write the right prescription? Did we miss an opportunity to give the patient the right medication? Did they refuse the medication because they were not educated and we did a bad job, just like the poll told us, right? Todd read out the poll. There are a lot of people who didn't get asked about these risk factors, and we could do a better job as medicine. So we now can look back and see how we did in the past and try to do better moving forward, as well as putting in standardized approaches for making sure we do all these things right the first time.
So when the patient comes in and and this risk assessment is done on them, who gets it? Where's it going? Because a lot of different people touch the patient. It can be an administrative person, it can be the surgeon, it can be a nurse, it can be a PA. Who ultimately is responsible for this?
Sure. So I'll give you an example. I don't want you to look at this and read every single word. I want you to get a feel of how complex this might be. This is a relatively complex flow diagram that in general, the average clinician doesn't love to look at. The people who like to look at this are computer programmers. If there's anybody out there on this webinar who's a computer programmer and they're like, oh, this I can follow. We built this into our electronic medical records system and made it easy. This thing that looks complex turns into a little checklist that the clinician would see. So if I'm the resident or the intern or the physician on the team, I get a little checklist where I can check a few boxes, and then up would pop the answer of what I should order for Leslie. And it guides us to that. And then that risk assessment is in the computer. Everyone on the team can look at it. And there's now a prescription. Leslie Lake is supposed to get low molecular weight heparin at 8 in the morning and 8 at night. And now the nurse knows what medication to give, just like the antibiotics or the blood pressure medicine or whatever else you need to get. Then it's clear we've done the risk assessment and we've ordered this medication, and now it's ready to go for the patient.
Okay.
And I think this is where we talk about the systems in place. If you ask the average person to just think about it and do it off the top of their head, it doesn't get done. But when we build this into the system, and we're not the only place that's done this, lots and lots of hospitals have something like this. This is the way to make sure that every patient gets a risk assessment every time, instead of just when Elliott remembers it.
I mean, this is fantastic. My fear is that not all hospitals have the resources or are as diligent as you are. So I think now might be, I know Todd has a question coming up, so I want to kind of run back to that, Todd.
Yeah. So, okay, everything's done in the hospital. The patients go home. why is it that patients are at risk of another clot up to, or for a blood clot up to 3 months post-hospitalization? What can someone do to prevent the clots from developing once they're at home? I think that's a big question for a lot of patients when
Yeah.
they're released. Is this a trend as people are pushed more into like day surgeries and are never educated on the risk of blood clots post-surgery, such as orthopedic, hip, knee, ankle, all that, Elliot?
Absolutely. So I think part of the reason is you're right. You're in the hospital shorter than you used to be.
Mhm.
Think back, 30 years ago when you had an inguinal hernia surgery, you came in the night before surgery, you had your surgery and you stayed for like 3 days. Now you come in at 5 in the morning and you're home by 5 at night. So part of it is that shortening of the in-hospital part. Part of it is also the risk factors that we've kind of we've hitched up with. You had major surgery and now you're home 3 days later, 5 days later, a week later, you still haven't recovered. You still have inflammation. You potentially still have an infection. You're still on antibiotics for pneumonia or urinary tract infection.
Mhm.
So you still have a lot of those risk factors
Mhm.
that you had while you're in the hospital. The difference is you have the same ones, but now you're in your house instead, or you're at a rehab instead. So some of those risk factors don't go away for a while, right? The inflammation around your knee joint, etc., as an example. So part of it is you're going to develop a new clot. Part of it is you might have had a clot in your leg, the day you're leaving, but you didn't know about it. It's a small clot. It hasn't caused any symptoms yet. Or, you just had knee surgery and you're expecting your leg to hurt. It hasn't swollen up massive and you haven't figured it out yet. So part of it is one of those two things. So the question you asked, which is probably the most important one, is what can we do to prevent this? And the answer is we're figuring out now. And when I say we, this is like the whole medical community, who is at high enough risk that they should go home on some of these medications. We used to only think that inpatients, hospitalized patients were getting these prophylaxis or preventive medications. Now we know there's patient populations that should go home on, 6 weeks or a month's worth of anticoagulation. And like I talked about before, the orthopedic surgeons were well ahead of this. They've been doing this for 30 years. So they would send people home on warfarin, for 6 weeks.
Mhm.
And that was a pretty common thing. Um, Other groups hadn't really done that. And now there's more and more data on which patients should have that. So there's a big project about orthopedic trauma patients. So patients with broken arms, broken legs, broken pelvis, um, about giving extended outpatient prophylaxis for DVT-PE in those patients. So that's one patient population, orthopedics, orthotrauma. Patients with abdominal cancer surgery. So if you or your family, is getting surgery for, I don't know, say colon cancer or ovarian cancer, some of those patients are now at such elevated risk that it's recommended that they go home with DVT prophylaxis. So talk to your doctor about that and ask that question. Should I go home on prophylaxis and what medication is right for me? And there's more and more of these things. I read a paper, I wouldn't say every week, but I read a paper every month or every few months of, hey, here's a new population. Patients with inflammatory bowel disease, they should get prophylaxis. When COVID was coming and we really didn't know what was going on with COVID and we were trying to learn about it, and we realized blood clots are associated with COVID, they were sending patients home. We were sending patients with COVID home on extended prophylaxis. So it is much more commonly used now than it used to be, I would say, even like 10 years ago.
Yeah,
So
and Elliot,
certain populations think about it and use it.
I've got to make this comment. Leslie knows, she already knows where I'm going with this because I'm in the patient support groups
Mhm.
and I see this all the time. And I really just want to make the comment that I think that we need to focus on uh, informing the patient why it's important they take their DOAC or anticoagulant properly, as prescribed, as directed, because I see a lot of people missing doses and not worrying a whole lot about it. And and for me, for me, that's a big thing. So I just think that's one thing we could, maybe focus on too, is explaining how each one works a little bit differently. So the patient really needs to know how they work, why they need to take it correctly, and how to take it correctly. That's just a comment I wanted to throw in.
No, I agree. I would agree with that 100%. And I will tell you, and I'll find the slide and I'll pull it up give me 1 second, about that exact topic, because I think it's a critically important piece about the patient education that you're talking about.
Right, right.
So, and this is this part about what are we going to do what are the steps to optimal pharmacologic prophylaxis, right? We talked about the risk assessment, the doctors are writing the right prescription, and we've worked for years to try to help doctors do the right thing there. But the medication doesn't work unless a nurse gives it to a patient who accepts it, right? This is the inpatient model. The analogous piece on the outside is the patient has to take their medication, okay?
Right.
And I think it's a really important piece in this puzzle right here. So we've looked at this data and we wrote about this, 15 years ago. 12% of these injectable medications were never given to a patient. These are inpatients in the hospital. And the most frequent reason is patient or family refusal, 60% of the time. And we looked at that at our hospital. We've now looked at it across our health system. Other groups around the country and around the world have looked at the same thing. VTE prophylaxis is missed in the hospital more than any other prescribed medication.
This is really shocking.
Yeah, it is.
And I'd worked with there's a nurse I've worked with for 20 years at Johns Hopkins, and she had really helped us getting the docs to write the right prescription. And she said the exact same thing. She said, and she's now been a nurse for like 40 years. So at the time, she'd only been a nurse for 20 years. And she's like, I can't believe it. This is embarrassing. This is shocking that we're not giving these medications to patients. And this drove our kind of next, 10 years worth of information to Todd, to answer your question of how do we educate patients and do this, right? So we actually tried to figure out, Leslie, like how is that happening? How is it possible that these patients are just not taking it? And it turns out part of it is probably driven by the nurse. As a physician, I come in and talk to the patient for, I don't know, 5 or 10 minutes a day, and the nurse is there 24/7. So the nurses had some misconceptions, and that was driving the patient misconceptions. They would tell stories like, if they're here for this certain thing, it's probably not that important, and I don't really push the patients for it. Or stories like, if it's the middle of the night and it's the only medicine, I don't want to wake up the patient, I'd rather let them sleep. And it's these stories because even the nurses didn't realize how critically important DVT prophylaxis is.
Wow. I mean, this is
Yeah.
really, it's really shocking.
And this is another thing that we hear all the time, that we know patients who are immobilized are at higher risk, but that doesn't mean that ambulation, walking around, is enough prevention for blood clots while you're in the hospital. And
So,
this is something that nurses have a misconception about. Physicians and therefore patients think, oh, if I'm walking, I don't need it. And that's just not true.
so Elliot, I want to keep the questions for the latter part of our discussion here, but there is a really good question in the chat right now that I am going to bring in, which is, what are the reasons patients give for refusing their medications?
Great question. So I think part of it is, nobody likes to get a shot. There are now more options for some oral medications, but in general, the mainstay of prophylaxis or prevention while patients are in the hospital are these shots. It used to be regular heparin given 3 times a day. So patients are getting a shot 3 times a day. People are like, I don't want to get a shot. Is there anything else I can do? Do I really need it? Why is it so important? They would say things like, well, my doctor didn't tell me about it. I'm in the hospital for pneumonia, and the doctor talked to me about my pneumonia, and that I'm going to get antibiotics for my pneumonia, and how my chest x-ray looks and my oxygen saturation, all these other things. And the doctors never talked about this. So I don't really think that medication's all that important. So it's not just the nurses. I don't want people to go away thinking Elliott Haut said it's only the nurse problem. It's we as physicians don't go in and talk to patients about this. And it applies to everybody. It's not the main reason you're in the hospital. You're here for recovering from trauma or cancer surgery or whatever. So if the docs aren't talking about it, telling how important it is, the nurses aren't in there re-emphasizing how important it is, it had never been explained to a patient. And I'm sure the patients on the call, sometimes they've come in and they've just said, before you knew much about this, okay, we're giving you this blood clot shot. And like, people are like, some are like, okay, sounds great. And others are like, what's that? Why do I need it? And then if there's not a compelling reason to get a shot 2 or 3 times a day, or even once a day, patients are refusing that.
Yeah.
And I think,
Okay.
Todd, that goes to your answer of why. And
Yeah.
we've talked to patients, we engage with patients, I'm not a patient, I've never had a blood clot, but I've talked to lots of patients with blood clots.
Mhm.
And they tell us these stories of why they're saying no. Nobody ever told me it's important. Why should I do it? If all these other things we say are really important, if this is important, then tell me about it.
Right. Thanks, Elliott.
Let's switch gears a little bit because we've talked a lot about anticoagulation, but there's a risk associated with that also, right? So, how do you, as the clinician, as the physician, how do you weigh the risk of placing a patient on anticoagulation and they develop bleeding versus the risk of them getting a blood clot?
And
Um,
it's a great question.
should patients ask for anticoagulation? And then, we talked about anticoagulation and then we talked about orthopedic surgeons, but they sometimes use aspirin, which is different than, taking a DOAC or, something else. So, how does this all get processed by you as the clinician? Because there is risk of bleeding.
Totally. And I think that's where that risk assessment plays in. So the risk assessment has the risk factors. So imagine this column, or these are the risk factors that elevate your risk of a blood clot. And then we also have a line of what things do you have going on that might increase your risk of bleeding. Okay, so for example, you've just had brain surgery, and brain surgery, if you bleed on the brain after brain surgery, it's a really big deal. So a little bit of bleeding is a really big problem. So the answer might be, in those patients, we're not going to give these prophylaxis medications early on. Okay, and you might have to wait 24 or 48 hours as an example. So you have to balance the risks and benefits. As we've done more and more research, we realize the risk is pretty small and the benefit is there for most patients.
Mm.
But when we do that risk assessment, it has both sides, and you have to balance the how much can I lower the risk of DVT-PE and what little risk of bleeding am I willing to take. I'll give you an example. In trauma, we used to wait patients who were bleeding from their liver or their brain or some other things. We used to wait days or even like a week before we started prophylaxis. We realize now it's safer to start it earlier, and there's been lots of studies that have shown that. So that's why we're doing it earlier and earlier now, and we're seeing lower rates of DVT and PE.
And what is that process of communication with the patient when they leave the hospital setting? You've said, okay, you need to stay on this for 30, 60, 90 days. You send them home. What is that conversation with them?
I think it's just like anything else. Like, hey, you had this infection and you need, 10 more days of antibiotics. So we're going to write you a prescription for 10 days of antibiotics. Or, hey, you now have a new diagnosis of high blood pressure. So here's your new blood pressure medicine. You might need to stay on this forever, but go talk to your primary care doctor about that. But this is usually it's going to be it's time limited. It's not, you're going to need to stay on this blood thinner forever, right? You're going to need to be on this blood thinner to help prevent a blood clot, and your risk extends for 6 weeks. So we think that's when you should stop it. We'll write a prescription for 6 weeks worth as an
Okay.
example.
Okay. Sounds good. Um, I know you've got some slides. I don't know if you want to share anything else with the group. Otherwise, we have a lot of questions and want to give people enough time to get their questions answered.
I I'm gonna do one quick thing, which today is a patient focused talk, and I want to talk about one project that is 100% patient focused. We actually worked with NBCA many years ago, way before Leslie was involved, and asked patients what did they want to learn about in the hospital about DVT-PE prevention. We did a survey online. Some of the people here might have even answered it. It was sent out on the website of some organizations, Facebook, Twitter. We got 400 patients to tell us their opinions, and they told us what they wanted. Who do they want to talk to? How do they want to learn about it? How long a piece of paper are they willing to read? Are they willing to watch a video, etc.?
Mhm.
And we wrote this paper, and I circled 2 people on this paper who are not our usual research co-authors. These are 2 non-physician, non-medical patients who both had PE and were helpful as patient advocates and helped us with this project.
Hmm.
And it came together, and this is us meeting with patients, and we put together an education bundle for hospitalized patients. You can get this for free. I'll put up a QR code later on. You can come read this anytime you want. It's a 2-page handout directed right at patients. It's available in all these different languages, free online at our website at Johns Hopkins. And we made a video that has been now viewed 300,000 times on YouTube.
Wow.
That this is this bundle. So now the patients, if there's any question they don't know about why we're giving these medications, we go in there with the SWAT team of education. Here's a piece of paper. You want it in English or you want it in Spanish or Chinese? Here's a video. You can watch it on this iPad we're going to hand to you, and we'll have a discussion with you. And that intervention, educating patients, dramatically decreases those missed doses. Patients are, in general, they want to do the right thing for their own healthcare. They just were not educated, and that was on us. And I think it's important that we try to fix that, and we've done this patient education for them. This video is 6 real patients telling their real stories, not actors, all about their blood clot experience.
Yeah,
So I
this
think
is
this
this
is
is
an-
fantastic.
And I'll find the QR code and put it up for the end.
And really,
Great.
this is why we do PEP, right? Because it's patients educating other patients and then having the clinician join us on a topic that is so very important to the patient community. So I want to be mindful of time because I know you're busy also. I don't know if you're in the hospital tonight or not, but I think, Todd, we should move to the uh questions. I'm gonna jump in first, Todd, if you don't mind, and then
Go ahead.
okay.
Hmm.
Um, how soon after surgery is it safe to start blood thinners? Are you worried that it may increase the risk of bleeding post-operatively? How do you assess and balance risk benefit? We've kind of touched on that, but I think it would be great for you to reiterate.
We kind of touched on it in general. I will tell you, this is a common question we even get. So, I operate on patients that are coming from home. I operate on patients that are already in the hospital. The surgical nurses are used to our system. Our system is the following. If you come in and you're having major abdominal surgery, we give you a dose of heparin before we put you to sleep for surgery. Okay? So we know that that dose is really, really important. And this all depends on exactly what type of surgery you're going to have. I said that declaratively, like it's for everybody. It's not really. So brain surgery is different. There's a few other things, et cetera. But in general, and what we do, I do big operations and they can get their heparin ahead of time. We have had to educate the nurses on the medicine floors where they're used to taking care of the medical patients, not surgical, that please don't hold that. That medication's critically important. We want the patient to have it. And we know the risk benefit is there's benefit to giving these medications.
Mm,
And then each type of surgery is a little bit different. Some surgeries you give it beforehand and you can give it, the evening of surgery. Some surgeries you can't give it ahead of time and you have to wait 24 or 48 hours afterwards. It very much depends on the risk of bleeding. Risk of bleeding after brain surgery is a much bigger deal than after hernia or gallbladder surgery, as an example.
sure. Well, we'll have to do another event with you in terms of reversal of blood thinners if you end up in the hospital needing surgery or have experienced trauma, but that'll be a different topic.
Whole
Todd?
different topic.
Yeah, so a couple of viewers want to know, you mentioned cancer and blood clots and cancer treatment. They're curious, they want to know how chemotherapy increases the risk for blood clots. How does that work?
I don't know that anybody knows the exact biologic mechanism of like this protein folds this certain way and does this thing. I think it is probably multifactorial. It's the cancer that you already have. So we know patients with cancer are at elevated risk. Uh, and then it's also the chemotherapy that people are getting. Some of those chemotherapies are also hormonal based. There's different types of treatment for different types of cancers, but
Mhm.
those patients are at high risk. Not every single outpatient getting outpatient chemotherapy should be on prophylaxis, but there are probably some patients that are at high enough risk that your oncologist or whoever's giving your chemotherapy might think it's appropriate. And that's a fair question to ask them, to
Mhm.
just say in general, hey, I know the most important thing for now is I need to hear about my cancer treatment. What's my prognosis? All these other questions. but also put it on your list, write it down. What's my risk for a blood clot? Should I be on something? If so, what should it be? And can you prescribe it?
And just to piggyback on that real quick, someone had mentioned they asked is prostate removal, and I'm very familiar with the prostate, so I get this. But is that considered major surgery?
It is considered major surgery.
Yeah.
And I would say the urologists have used to say that they were not giving a lot of prophylaxis. And then they would have some patients with events and they would do fine after their surgery. And, they would, call to check up on them 3 weeks later and they had died after their pulmonary embolism. And more and more urologists now are giving prophylaxis. I will say with the advent of robotic minimally invasive surgery, it's a less invasive operation than it used to be.
Mhm.
When I was doing those as an intern on the urology service a very long time ago, it was an open operation. It was a much, much bigger deal. Now I think the robotic way, people are going home maybe not the same day, but 1 or 2 days later, it is less invasive, but it's still major surgery.
Yeah. Thanks, Leslie.
That's great. What about pediatric patients? Are they treated differently? Are the prophylaxis methods different? Can you use DOACs? Can you speak to pediatric patients?
It's a great question. It is an interesting one because they're different. So some people think, oh, well, pediatrics, they don't have any events. That answer is not correct.
Mhm.
They are much less risk of events, but we think of that in the really little kids. We've looked at it in trauma patients, and we had a resident who wrote a paper about this years ago. And like little kids, their risk is really, really, really low. And then once they hit puberty, about 13, their risk rapidly turns 13 is about equal to 18 or 25, right? They're not as high risk as the 70-year-olds, but in trauma specifically, that risk, it doesn't change when you hit 40. That risk changes when you hit 13. So we now have risk assessment tools that look at the pediatrics population specifically to try to figure out which of those patients get prophylaxis. And then the question is, well, what's the right medication? I take care of 15-year-olds who are as big as me and have a thick old mustache. So they get adult dosing. It's a very different dosing regimen in a child who is, 3 years old, 5 years old, etc. There's weight-based dosing, there's things like that.
Yeah, and we have, I think, somebody just put into the chat function, we have great resources on pediatric VTE, and actually your colleague and one of our MESA members is Dr. Neil Goldenberg at All Children's Hospital at Johns Hopkins, who's probably one of the world's leading pediatric VTE clinicians. So
Maybe you'll have to have a VTE and pediatrics session for one of the pep.
yes, and he is in Tampa, and so we are holding our breath and wishing all of those folks well down there that they're safe through this storm. All right, Todd?
Okay, so we can throw two quick questions into one. Somebody's asking about, the leg squeezers, the mechanical compression that you wear in the hospital bed. Is it a good idea, and where do is it a good idea to use those at home? And can you go out and buy them? And the other part of that question is, should you wear compression all night long?
So those are two different but really good questions. The mechanical devices, the sequential compression sleeves, it used to be they were in hospital only. It was a big, expensive machine that, I would, patient one would use it, then patient two, then patient three. They would each use the same machine with the disposable little sleeve getting changed out. But the big pump machine was the expensive part and you couldn't go home with it.
Right.
Now there are actually home devices that can be prescribed and sent people home with them. I don't personally use them, but it is being recommended in a few small patient populations, maybe some of the orthopedic joint replacements. I would ask your doctor about that specifically. It is now a possibility to go home with these mechanical devices. Now, don't forget
Will insurance
pneumatic.
cover that?
I'm not the insurance coverage question answer. I do not
Okay,
know.
fair enough.
That is an ongoing problem. But these are mechanical. They're pneumatic. They're electric. They go in and out. They squeeze from the bottom up. They do that, which is different than compression stockings that we could talk for hours about compression after you've had a DVT wearing those tight compression stockings There's benefit potentially when people fly. I wear them when I fly long distance.
Mhm.
That's a whole separate topic about compression stockings like that is different than these mechanical, pneumatic compression devices.
Sure. Thanks, Elliot.
Okay. If my DVT was caused by my hernia repair surgery, what could I have done to prevent it?
So it's a good question. And I think the answer goes to what I talked about before. So we look at and we ask this question of, did you get perfect prophylaxis? Step one, did you have a risk assessment? Did somebody look at you and say, how old are you? What surgery are you having? Are you in the hospital? Do you have any other risk factors? And then what's your risk of taking these medications, and make a conscious decision of you should or should not get prophylaxis. That's step one. Did you get a risk assessment done? Step two, did the person ordering, doing that risk assessment follow the recommendation? If it says to order you heparin and I don't, that's on us as a medical care team, that the recommendation is you should get it and we didn't give it to you. So there might be a failure of getting a risk assessment, a failure of getting the right prescription. While you're in the hospital, did you get every single dose? Did you get your morning,
Welcome, everybody.
afternoon, and
You are
evening
on
dose?
PEP.
Oh,
Yep.
so
Not sure what that
I
was.
think that question of, then we know it was, potentially preventable because we didn't give you a risk assessment. We missed a few doses while you're in the hospital. That's what you could have done differently. The answer might be, nope, we did everything right. We gave you the right medicine. You got every dose every single time. And that's the case of, the medications are not perfect. These are not perfect. Just like people still get infections even after we give them the right antibiotics before surgery, it's not perfect.
Mm-hmm.
Okay. Um, I want to make sure we're just mindful of time. It's 8 o'clock, so I think we're going to stop with our questions. I'm sorry that we can't get to everybody. Elliot, we did have a request for the initial assessment screen. Again, is that something that you would be willing to let NBCA share with folks
Yeah.
if they wanted it?
I did not, I only showed you one research paper tonight. I have a whole talk. It's an hour long. It has 100 slides and 50 research papers. I have them all written there. I am more than willing to share. That algorithm is right out of a paper we wrote in the British Medical Journal. And
Awesome.
I'm
Great.
happy to share that with you. We have if people are really interested in the science behind some of the stuff I was talking about today, go to the bit.ly blood clots website. That takes you to our Johns Hopkins website about blood clots. You can get the handouts, the patient education handouts. If you're a patient and want to read it in whatever language, feel free to print it out and give it to anybody. You can watch our patient education video. And we also have a piece about the research we do, the interventions we have, links to the research papers, things in BMJ, JAMA, etc. So feel free to get all that information there. And Leslie, I'm absolutely willing to share any of those resources on the
That's fantastic. So everybody who's on the call, if there's something you need, please feel free to reach out to NBCA and we'd be delighted to share. And then I think we have a very interesting mix of people tonight. We have obviously patients because this is a PEP event, but we have a fair amount of healthcare providers that have joined as well, who are eager to learn more about this topic. And I'd like you to commit to us tonight that we can have another webinar with you that'll just be focused on the healthcare providers because they need to be educated as well on this incredibly important topic.
Leslie, I love you, and I knew you were going to do that to me. And Leslie and I talked about it online or ahead of time, that this was a patient focused, and I tried not to get too into the weeds of the research and the methods and all, like clustered randomized trials and all that stuff. But I haven't, like I said, there's an equivalent version that's really focused on physicians, nurses, pharmacists, that I'm happy to do anytime we can have another webinar. Obviously, the patients are welcome too, but today was really a patient focused discussion. But I am more than happy to talk about, how do we do these things? How do we build the decision support tools? How do we implement the patient education bundle? Where did our funding come from? What's our hypothesis? What's our testing? What's our statistics? I'm happy to do that part anytime as well.
Fantastic. Okay. We are, I think we have some exit poll questions. But Elliot, want to thank you for joining us tonight. This was absolutely fabulous. You're just an incredible source of information, a wealth of information, and we thank you for sharing with us tonight.
Absolutely. This was a lot of fun.
All right.
Yeah, thanks a lot, Elliot. We're going to let's just do it real quick here, the exit poll. Number one, if you have surgery or go into the hospital in the future, do you now feel more qualified to discuss hospital-associated blood clots with your medical team? Yes or no? And just one more question, if applicable. How long ago did you develop your most recent hospital-associated blood clot? 0 to 1 year, like now to 1 year, 1 to 3 years, 3 to 5 years, 5 years and beyond, or not applicable. If you folks could just answer those real quick, we're going to pull up the results and then we'll say goodnight to you.
I love our pep talks.
We learn something every
I'm
single
always amazed at what I
month.
learned.
My notebook is always filled with notes.
Yeah.
Okay, so here you go. Number one, if you have surgery or go into
Wow.
the hospital in the future, do you now feel more qualified to discuss hospital-associated blood clots with your medical team? Nice. 98% said yes, 2% said no. If applicable, how long did you develop, long ago did you develop your most recent hospital-associated blood clot? 15% said about a year, 10% 1 to 3 years, and 5% said 3 to 5 years. And the last one, 5%, 5 years and beyond, and not applicable was 66%.
Awesome. Thank you, Todd.
You're
All
welcome.
right. Thanks everyone for attending, and we look forward to hosting next month's PEP. And Elliot, we'll get you back up here for another webinar.
Absolutely, anytime. Thanks for having me.
Good night,
Thanks,
everybody.
Elliot. Good night.